The subject of my talk is radiological treatment for fibroids, and the learning objectives are to describe the radiological treatment options, particularly uterine artery embolization and high-intensity focused ultrasound, to present the current evidence on the outcomes of those treatments and how to manage expectations and complications. The main radiological treatments are uterine artery embolization and MR-guided focused ultrasound. There are others, such as MR-guided transvaginal cryotherapy, RF ablation, but these are not mainstream, so I will concentrate my talk on UAE and MR-guided ultrasound. The indications for treatments of fibroids include severe menorrhagia, dysmenorrhea, anemia, and pressure effects from the fibroids on bladder and bowel. There are contraindications to treatment, obviously if women are pregnant, or if there is a suspected malignancy of either the uterus or ovaries. If people have contrast allergies or renal impairment, then uterine artery embolization is contraindicated. And if the woman is unable to accept the risk of having a hysterectomy under any circumstances, then it is foolish to proceed, as there are complications that are rare but may require hysterectomy. I'll describe uterine artery embolization first. The aim is to catheterize and embolize both uterine arteries. And as you can see from the diagram, the femoral artery approach is the usual approach. It can be unilateral access, where you go contralaterally to the opposite uterine artery and then pull back into the ipsilateral uterine artery, or you may use a bilateral common femoral arterial approach. If you practice day case uterine artery embolization, then the radial artery is also a very viable method of access to catheterize the uterine arteries. The aim is, once you're in the uterine arteries, to block them, particularly the side branches to the myometrium, with particles of different sizes, and to keep patency of the main uterine artery to some extent, expecting very sluggish flow. But some operators do go for full cessation of flow in the main uterine artery. The advantages of uterine artery embolization are it's a total treatment of the uterus. So the number and the size and the position of the fibroids is actually irrelevant. The more fibroids, in many ways, the better the treatment. It's minimally invasive, so it's performed under local anesthetic, and it's repeatable because there is no scarring, and patients have a rapid recovery, and this is what makes it particularly attractive to many working women. On the other hand, MR-guided high-intensity focused ultrasound acts by denaturing the fibroid by heating it to very high temperatures. It's totally transcutaneous, so there is no needle involved, there are no catheters involved, and no anesthesia is required. So it truly can be an outpatient treatment. However, patients do need to be able to lie prone in the MR scanner for several hours. There needs to be access, a window of access to the fibroid from the front of the patient as she lies prone, and that means the bladder and any interposing bowel have to be displaced, and usually a scar in the lower pelvis is a contraindication, as that absorbs the energy. It is said that the hyperintense fibroids, which have more perfusion, have a lower long-term success because the heat is taken away by the perfusion. Fibroids in the posterior wall of the uterus are also harder to treat because they are closer to the sacral nerves, and that causes pain, so there's shorter sonication time. And there is a size limit because you have to direct the beam at the whole of the fibroid. Fibroids larger than 10 centimeters are generally not considered suitable for this treatment. The aim of both treatments is the same, and that's total infarction of the uterus. You can see the pre-treatment uterine MR scan here showing good contrast enhancement in both fibroids here, and then after treatment, complete infarction with no evidence of enhancement of the fibroids at all. Unfortunately, you don't know whether you've actually achieved 100% infarction until you follow the patient up down the line. And there are some fibroids that have some residual blood supply to them, and this leads to fibroid recurrence and recurrence of symptoms. So generally, we know that the results are best if you can achieve 100% infarction, symptom control is better, and the reintervention rate at 5 years is much lower. With different degrees of infarction, you see the symptom control diminishes, with the worst results when you have less than 90% infarction, with a 20% reintervention rate at 5 years. How to achieve 100% infarction is difficult to know. There are multiple types of particles that we can use, but superiority of one particle over another has yet to be proved. Here's a systematic review and meta-analysis that we performed looking at all the articles in the literature. The only paper that showed a difference was between embospheres and spherical PVA, where embospheres demonstrated greater percentage fibroid infarction, but spherical PVA is no longer available and used for this indication. When we look at all the other agents, a mixture of gelatin sponge, non-spherical polyvinyl alcohol, and all the calibrated spherical particles, we have yet to show any difference in outcome. So we need more evidence, more randomized controlled trials between these different agents to see whether one or other is superior. There is one very recent paper in the literature that's undertaking a randomized controlled trial between gelatin sponge and embospheres. And in a very small cohort of these patients, 6-month UAE fibroid spectra were obtained on MR spectroscopy. The operators looked for choline. They looked for a variety of biomarkers, but here choline is a biomarker of tumor cell proliferation. And although in all these patients 100% infarction was considered present on the MR scans, in fact, when they looked at the choline spectra, they could see that the embosphere group had lost all the choline spectra in all the patients, whereas the gelatin sponge group, even though their fibroids did not enhance, there was still choline spectra within 2/3. And it's perhaps work like this that will tell us whether one agent or another is much better at achieving true infarction. But both these treatments suffer from the same problem, and that is the uterus remains. So just as myomectomy, when the uterus remains, there is a risk of either new fibroids forming or some smaller fibroids being missed, or some fibroids finding in blood supply, so there is a re-intervention rate. And uterine artery embolization and myomectomy look much on a par, and it's difficult to know whether one treatment or another is actually better and has a lower re-intervention rate. The randomized controlled trials that we have, the first 4 that were published, really compared uterine artery embolization with hysterectomy. And this is like comparing apples and oranges. One of these leaves the uterus in place, one removes them. So of course you're going to find more reintervention for fibroid symptoms in the treatment that leaves the uterus in place. So here we know that the results of these trials show more reinterventions were required for the patients in the uterine artery embolization treatment group. Not surprisingly, there were more major complications following hysterectomy, but there were more minor complications and delayed complications out to a year, and sometimes much more than that following embolization. So very different outcomes. However, despite the fact that after embolization we know that a certain proportion of women will require a re-intervention, uterine artery embolization has still been found to be cost neutral compared with hysterectomy at 5 years. And many people felt originally that because the fibroids were not being removed and volume reduction was variable, that perhaps the symptomatic response from pressure effects from the fibroids would not be so great. In fact, many of those trials have actually shown a greater response on the pressure symptoms than with hysterectomy, which perhaps needs some explanation as it's not intuitive. If we look at the 2 trials that have been published so far that compare embolization with the other uterine-sparing treatment of myomectomy, then we can see that we have much more similar results. This is the first trial from the Czech Republic, and here we can see that the cohort of women being treated generally had single myomas And many of these were not particularly large, as 2/3 of the myomectomy group were suitable for laparoscopic myomectomy. And at 2 years, they found no difference either in the symptomatic effectiveness, the post-procedural FSH levels, reintervention rates, or complications. So here, the two treatments seem to have the same symptomatic response and outcomes. My own institution published the FUME trial, and our population group, I think, is quite different. We see women with very, very large uteruses with multiple fibroids within them. And here we compared 82 women who had uterine artery embolization with 81 who had abdominal myomectomy, with the attempt by the gynecologist to perform fibroid clearance, so all these fibroids would be removed. The symptomatic responses were much the same. Major complications were greater in the myomectomy group than the uterine artery embolization group, but this was not statistically significant. And at 2 years, the reintervention rate was greater in the uterine artery embolization group than the myomectomy group. But we really need much more evidence, and we've recently completed in the UK another trial comparing uterine artery embolization with all types of myomectomy. We've stopped recruiting now and are in the follow-up period, and we hope to get more results about the differences in treatment so we can advise women accordingly. But one of the areas that I think we still can't really offer evidence-based advice is in the role of uterine artery embolization in women who want to preserve their fertility or are actively seeking fertility. This is the NICE evidence, and you can see here the wording says that patients contemplating pregnancy should be informed that the effects of the procedure on fertility and on pregnancy are uncertain. That doesn't mean that the literature is stating that the results are poor. It's stating quite simply that there isn't sufficient literature to be able to produce evidence-based guidance, and they encourage further research. So what do we know about the effects of embolization on fibroids? We know that the arterial flow to the ovary is likely to be transiently occluded during embolization. We see filling of the ovarian artery during our embolization procedure. But despite this, the incidence of clinically apparent injury to the ovarian reserve is very low. There are about 10 studies that have been assessed by these authors looking at hormonal assessment of ovarian reserve, measurements such as anti-Müllerian hormone, and they found that in women less than 45 years there were no observable effects on the ovary. But this is based on only 10 studies, and they recommend that there is more study, more evidence before definitive conclusions can be reached. And this is one of the aims of the FEM trial, where we hope that we will be able to look at ovarian reserve in the two groups of women and come up with some evidence-based advice. The other evidence we have is based on systematic review of numerous case series and case reports in the literature. And there is some discrepancy here. These authors in 2013 looked at 21 studies and looked at the pregnancy rates after uterine artery embolization and compared it to the age-adjusted rates in the general population. And what they found was that the cumulative pregnancy rate was very similar to the age-adjusted pregnancy rate. The mean age of these women was 36 years. And we know that many women presenting with symptomatic fibroids are in their late 30s and early 40s. So their pregnancy rate is not as great as in the younger population. And they had a miscarriage rate of 28%. And again, we know that fibroids are associated with an increased miscarriage rate. But their conclusion was that this was comparable to the age-adjusted population. And they point out that if we look at the pregnancy rates in women having embolization for another indication, such as postpartum hemorrhage, this is a much younger group of women, then the pregnancy rates are much, much higher. So the implication is that this really does not affect the pregnancy rate. On the other hand, an earlier meta-analysis and review showed a different result, saying comparison in completed pregnancies in women with fibroids, those who'd had uterine artery embolization compared with women with fibroids but who had not undergone uterine artery embolization, and they found a spontaneous abortion rate which was much higher and a postpartum hemorrhage rate that was much higher, though no changes, no difference in the preterm delivery, intrauterine growth retardation, malpresentation, etc. So we still don't really know what the advice should be. And so I usually refer to the clinical recommendations, the guidelines produced by the two colleges in the UK, where they say the evidence for the beneficial effect of either myomectomy or embolization on fertility and pregnancy outcomes is weak. And that embolization can be offered to women considering fertility, but it must be done on an individual basis and with counselling and review by fertility specialists. And I'm talking mostly about uterine artery embolization because this is where most of the evidence has been obtained, but as far as we can tell, the results of magnetic resonance guided HIFU are more or less the same. But women have to understand the procedure and understand the limitations of it. And this is very important. As an interventional radiologist, we tend very often in the past to have just done procedures and left the discussions and the follow-up to our clinical colleagues. Here it is absolutely vital that radiologists have a radiology clinic, that they see patients, they provide them with patient information leaflets, and really explain the procedure so that the expectations of each woman are realistic. There are numerous misconceptions. These are about 5 of the most common misconceptions, and I'll go through them one at a time. The first misconception is that because fibroids are present, they need to be treated. Most fibroids have no symptoms. This is not a cosmetic treatment, so just because there might be a large fibroid present, if it's asymptomatic and not thought to be causing any problems, then there really is no indication for treatment. The second very big misconception is that the fibroid will shrink. It will shrink to some extent, but if you start off with a very large fibroid, even a 50% reduction leaves you with a very large fibroid. And the results, again, from embolization and focused ultrasound are comparable. So volume reduction is not the aim of the procedure, and in fact, women can have very, very good symptomatic improvement with no volume reduction at all. This is a patient where I would have advised her that this large fibroid after embolization would remain present and large. In this particular case, we had a fantastic result. You can see 6 months later that that fibroid has effectively disappeared and she's got a normal-sized uterus. Now that sounds and seems fantastic, and this is one of the problems with submucosal fibroids. They can actually pass completely. This is not without problems, though, such as large fibroid, if trying to pass through the cervix, will become impacted. And this is a previous patient, not the same one as imaged here, where you can see this very, very large fibroid came away in toto and had to be hysteroscopically removed because it was causing impaction. Another problem is that the submucosal fibroid will degenerate and may liquefy and come away as a vaginal discharge, and this can be extreme. If it is like this, where we call this a chicken soup discharge, the patient will often need a gynecological procedure with hysteroscopy and sort of curettage removal of as much of the material as possible so that they can stop this discharge. And this particular patient, as you can see, went on with a fantastic result. Another misconception is that maintaining the uterus maintains fertility. We know that in some women we will induce a premature menopause. This is very uncommon in younger women, but can happen in women over 45 years of age, so it's age dependent. We know that infection can occur, and if we cannot control infection, a woman might require hysterectomy, and we don't know what the effects of infection are. They may cause endometrial scarring and problems down the line with fertility. And the other misconception is that once treated, no other treatment will be necessary in the future. We know that the younger the patient is at first treatment, the more likely this is that retreatment will be required. It's age dependent, so for women less than 40 years, there's a 25% chance for 5 years that they will require a further treatment, and that can be a repeat embolization, it can be myomectomy, or they may choose to have hysterectomy. And the last misconception is because it's minimally invasive, it doesn't cause pain. The procedure is not painful, but the after effects certainly are. You get a uterine ischemia, and this peaks within 2 hours and takes about 10 hours to come back down. So we need to manage that pain, and using a hypogastric nerve block, as shown here, very simple radiological procedure, which has been shown to really make a big difference with morphine dosage compared with epidural, and a very straightforward procedure that provides 8 hours of pain relief. So the take-home message from this talk is that actually you need to understand and be able to discuss the full range of treatment options with your patients. You've got to encourage realistic expectations, or there may be disappointment, and you must act as a true clinician and not leave all the clinical aspects of treatment to your gynecological colleague. Thank you very much for your attention.